Thanks for that introduction, and thanks to all of you for putting up and listening to me one more time today. Really excited to share our full cohort results looking at the variability of Cabotegravir, Rilpivirine after 1 year of continuous use. So I have nothing to disclose. I'm not sure what more I can tell you guys about Cabotegravir, Rilpivirine as a background that you haven't already heard, but just as a quick review, it's the currently only FDA-approved full complete regimen for the treatment of HIV infection. And what we know from both clinical and real-world cohort data is that it's highly efficacious with week 48 outcomes having a high ability to virologically suppress individuals who were already previously virologically suppressed, anywhere between 90 to 99% efficacy on that front. What also we've seen, though, with patients and participants is that even with on-time injections and essentially now perfect adherence because we're controlling it from a clinical standpoint, is that potentially that low drug exposure or certain risk factors such as elevated BMI, history of NRTI resistance, et cetera, might be associated with those participants experiencing virologic failure. In addition, I think there's been a lot of data or emerging data that a lot of you in the room have been involved in producing and have presented on, that within the first 12 months of utilization, there's a significant amount of both so between patient, and then also intra within patient variability. In addition to that, there's ranges in terms of the percentages of trough values that have fallen below the proposed 4 times PaIC90 threshold. And so because of all of this and, the data from those first 12 months of use, our question that, our group thought about was, are there certain patient-specific factors that might be influencing both this within and between patient variability, specifically after patients have been on these drugs for a prolonged period of time? And so we conducted a prospective single-arm observational cohort study in participants who have received at least 12 months of continuous long-acting Rilpivirine at our HIV clinic. We aim to evaluate and characterize both the inter and individual trough plasma concentrations of these two agents, and our overall goal or hypothesis was that certain patient-specific characteristics would influence potentially both the Cabotegravir and Rilpivirine concentrations and variability. So here's a brief schematic of our study design. As you can see, we enrolled participants, and then at each study visit, right before their next injection, we obtained true trough, or quote-unquote, true trough concentrations prior to the next visit. Our primary outcome is listed for you on the slide. Additional secondary outcomes, we looked at the proportion of participants who fell below those proposed efficacy concentration thresholds, as well as any laboratory or clinical characteristics that were associated with patients or participants potentially falling below those concentration thresholds. To be included within our study, people or participants had to have received greater than 12 months of continuous Rilpivirine, dosed as there every 2 months, like I said before. In addition to that, in the 12 months leading up to study enrollment, they could have no missed or out-of-window injection doses in those 12 months prior or during the study period. What I can comment on there is we initially allowed for participants, if they were bridged with oral Rilpivirine, to also be included if they were outside of that planned injection window for any reason on that front. In terms of sample preparation analysis, we had the same 2 nurses administer all injections to participants to hopefully control for some of potential injection site practice variability there as well. These 2 nurses have also been in our clinic administering these drugs since the Atlas and Blair trial, so highly experienced in terms of their injection technique. Plasma, again, was obtained at entry in those 2 follow-up visits immediately prior to the next injection, and we utilized validated LC-MS methods. Our lower limits of quantification are listed for you on the screen there. For analysis, for our primary outcome, we looked at percent coefficient of variation and interclass correlation coefficients. And for our secondary outcomes, we analyzed the data using Fisher's exact or Wilcoxon rank sum tests. So here is our participant demographics at entry. We screened 54 participants. 4 were excluded because in the 12 months prior to enrollment, they were bridged with a non-Cabotegravir Rilpivirine containing oral regimen. For insurance purposes in the US, it was easier to get them back onto Bictegravir, emtricitabine, TAF than trying to go through the process of getting them the oral Cab Rilpivirine. So as you can see, our demographics are very reflective of our overall cohort of patients at our UNMC HIV care clinic. Things I want to highlight, our body mass index on average was 28, and then the duration of Cab Rilpivirine for all participants, the median at enrollment was 65 weeks, so significantly over the 48 weeks for a year-long mark. Getting into our results, we had 150 trough samples, so 3 trough samples from each of our 50 participants. Here's our Cabotegravir data. As you can see on the graph on your right-hand side of the screen, I think the plot itself speaks for itself in the sense of lots of variability, not only within, between patients, but also within patients as well. Visits are listed on the bottom, the concentrations on the y-axis. What we saw is a mean of 1384 nanograms per mil. We had 8% of the total trough concentrations fall below the proposed 4 times PaIC90 threshold. Interestingly, inter-individual variability was 58%, intra-individual was less at 24%, and then when we look at the interclass correlation coefficient, which assesses how well those agreements are within a single participant, we found it to be 0.82, and an ICC above 0.75 indicates good agreement, so meaning that the concentrations within one person like agree well with each other. Here is the data for Rilpivirine, structured very similarly to the previous slide. I think even more so, the graph kind of speaks for itself when you look at the variability with Rilpivirine. Even after a year of continuous utilization, we had a geometric mean of 83 nanograms per mil in this cohort. Significantly more concentrations fell below that proposed threshold for Rilpivirine in comparison to Cabotegravir. Inter-individual variability was similar with Rilpivirine as it was with Cabotegravir at 52%. Intra-individual-wise, 23%, but I think that number might be slightly misleading median-wise, because when we look at the intra-class correlation coefficient and we truly look at what that variability is within that one patient or participant, that comes out to be 0.72, and 0.72, an ICC of 0.72 indicates moderate intra-individual agreement, meaning there's potentially a little more variability with the Rilpivirine within one patient in comparison to the Cabotegravir. We also looked at, based on our secondary outcomes, what were characteristics associated with potential Cab or Rilpivirine falling below the 4 times PaIC90 in participants. I have a little footnote at the bottom that might be hard to see, but in addition to what was listed on the side, we also looked at sex, race, serum creatinine, total bilirubin, and alk phos, and all of those were explored but not associated with being predictive of falling below the efficacy or concentration threshold. What we did find, or actually the only thing in our cohort that we found to be statistically significant at predicting being low in terms of your trough concentrations, was having a lower albumin level, as you can see there. So in conclusion, what we saw is that in comparison to the previous data from the initial 12 months of use, after 1 year of continuous utilization, variability was pretty similar. High inter-individual variability was still observed, whereas in our cohort we saw moderate for Rilpivirine intra-individual and good for Cabotegravir inter-individual variability. Within our cohort, the only thing that was predictive of potentially having lower trough concentrations was lower albumin levels. As you can see from the sub-bullet point, more participants were likely to have a Rilpivirine concentration lower in comparison to a Cabotegravir concentration. In terms of, now that we have our full clinical cohort of data, moving forward, what our group would like to do is, population pharmacokinetic modeling development to kind of help take into account this variability as well as maybe figuring out, specifically when participants are maybe falling below concentration thresholds. And then I think clinically, I may have not spent a good enough time on this earlier, but with all the talk that we've had about therapeutic drug monitoring and everything going on this front, I think this variability, even at, the 1 year continuous mark and people have been on it, or participants or patients have been on the drug for a long time, it's still something we need to consider if we're going to be performing therapeutic drug monitoring. And so with that, I'd like to thank my collaborators and my co-researchers, my mentors, obviously the clinic staff for all their support, as well as our participants and our funders. Thank you.